Good morning, everyone. Thank you for joining our first MEP APP quick review. And today's topic is going to be focused on chemical burns and high pressure injection injuries. Just a little background, I think most of you on the call know me as the lead PA for MAC 3, but my name is Brooke Redmer. I recently took over the lead PA position for MEP APP education and training. So I'm really excited to bring you this APP quick review with Kathleen at Cheseldine, who is the PA educator for MedStar Southern Maryland Hospital Center. So we're really excited. Thank you all for joining us and taking the time out of your day. Just a reminder for anybody who did not register for the event, this is worth one category CME 1 credit. And if you did not register with Cytel, just drop your name in the chat over here on the side for me, and I can submit the attendance after the fact to Cytel to make sure you get your credits as well. All right, Kathleen, you want to head over to the next slide? So we're going to briefly talk over our learning objectives for the event. This is our major CME slide for this, so you can take a look at that in terms of what credit you will get. But our brief learning objectives are to be able to perform appropriate exams on patients with chemical burns and high pressure injection injuries, identifying the red flags to look for with these types of cases, preparing your history, and finding key pertinent information that will help you identify emergent components, recognize when to consult specialists for guidance on these types of injuries, and identify which members of the team can help you facilitate a disposition for these patients, and of course, to integrate a team-based approach care plan for these patients. And again, this is your category 1 CME credit slide information, and on to the next slide, we will have some information on how to access your cloud CME. And that's where your transcript will be. All right, without further ado, I'm going to turn it over to Kathleen to get started her presentation on chemical burns. Thank you, Kathleen.
Great, thank you. All right, so we're going to talk about chemical burns. Kind of how this came up was that I had a kind of an interesting case. I had a 51-year-old male who came in for evaluation of a facial burn after he had an explosion of calcium tungstate into his face while he was using an industrial oven. So it was for his job. He was working the overnight shift. He lit a pilot light in this oven, and then the explosion of this chemical occurred. He did have singed beard and nose hairs that triage noticed when he was being evaluated. He was mainly complaining of eye irritation, and he had some right-sided facial redness and irritation as well. So he did notify his supervisor of the injury before he left, but he didn't really have significant knowledge of the chemical that he was working with. He was not wearing any eye or face protection when this happened, and he didn't have any type of decontamination or anything before he left his job site, and he didn't contact EMS or anybody prior to leaving. He just drove in. So he came in still wearing all of the clothing and everything from the exposure. So this just kind of brought up some interesting kind of questions and things to think about, because I don't think it's very often that we see someone coming in with something like this, especially from an industrial chemical. So some of the initial steps that we had to kind of think through was trying to protect the healthcare workers from a secondary exposure to that chemical, because he was still wearing everything that he had been exposed in. He had obviously already been removed from the location of exposure, but that's another important component. Removing all the clothing and jewelry that was involved with the exposure and deconning the patient. Those are all kind of the first things that you have to think of. So we didn't really know anything about this chemical, but because he was complaining of those singed hairs, it was really important that we evaluated him closely right away. So I actually just put a mask on. I put one of our gowns that we've been wearing for COVID, and then, gloved and some eye protection just in case, because we didn't know what we were dealing with. And so I'm going to talk about kind of what we actually have that can help to evaluate these patients to protect the healthcare workers. But the patient was extremely stable, no airway compromise. So we actually just kind of got all of his clothes off, bagged them up, and we have a decon shower in our emergency department. So he immediately got in there to just wash off. Irrigation and decontamination is the most important part of chemical burn evaluation. In most cases, water is the best thing to use for this. There are a couple exceptions of chemicals that don't really respond well when you use water, but they're kind of few and far between. And the interesting thing with chemical burns, and the thing that makes them very different from thermal burns, is that the tissue damage is occurring as long as the chemical is in contact with the skin. So with thermal burns, the patient, if they touch a hot stove, they immediately remove their hand. The burn itself is done and the damage is done, and then you have to deal with that at the time. But with chemical burns, the damage can still be happening even when the patient presents to you, as long as there's still chemical there. And getting through deeper layers of the skin can lead to systemic exposure. So getting that chemical off is the most important thing. There are things besides what we just used, like in the time of COVID, that can be used for us when we come in contact with these types of patients. It varies depending on what chemical you're dealing with, what you might need to use. But we actually do have people at our site, the emergency preparedness team. We have contact people who kind of deal with these situations, and they focus both on these types of chemical exposures as well as like really harmful infectious exposures that we might come in contact with. So we do have things like PAPRs and protective gloves and things to gear up into for these patients if needed. You just have to figure out who is your contact at your site in case this would ever need to occur, and just maybe have that contact kind of stored somewhere just for the future. Not that we see these all the time, but OSHA actually has a classification of the levels of personal protection as well. So when you look up a chemical on the OSHA website, they have this big database of chemicals. You can see what level of protection you need to have, and OSHA just kind of lays it out right there next to the chemical. So that's pretty helpful to know what you might need to use to be protected. And the other people that help a lot with this are also poison control. They can kind of tell you what you need and how harmful the chemical might be with a secondary exposure. So the solution to pollution is dilution, was what my college chem professor said ad nauseum. So whenever you think about these chemical burns, you want to use a large amount of warm water at a low pressure. It is important to remember the low pressure part. We always think about kind of higher pressure irrigation for things like lacerations that we're trying to clean out, but a high pressure irrigation of a chemical can spread it to other unaffected areas. So making sure that it's kind of a lower pressure, just copious amounts of warm water is most important. The actual duration of irrigation, the method and duration is pretty limited as far as the evidence behind that. But it seems like alkali burns take longer as far as the irrigation that's needed. And the way that we kind of check this is to actually evaluate the pH of the skin. You can use like a pH strip, which we're going to talk about. So chemical burns often cause partial thickness burns. About 50% of them are partial thickness. The burn size is usually pretty small, less than 10% of the total body surface area. They often don't get infected cellulitic after the fact, but it's a similar kind of way to manage a thermal burn. A burn care specialist really should be consulted if it's a really high risk area. We think face, hands, genitals, or any significant exposure like signs of skin penetration, erosions, blisters. So similar things to think about as far as chemical burns versus thermal burns in those cases. The eyes, I think, are where we probably see the most kind of chemical exposures in the emergency department. I know I've seen quite a few of these with people splashing bleach in their eyes and other kind of home cleaners. That requires immediate treatment to prevent vision loss and permanent damage. Alkaline substances also, in this case, are more dangerous, but acids can also do some pretty severe damage. Patients might come in with decreased vision, eye pain, blepharospasm, where they don't feel like they can open their eyes, some conjunctival injection, and photophobia. In the US, the injury from chemical ocular burns actually happens most often in children's ages 1 to 2 because they're splashing themselves with some of the household chemicals. alkaline examples of just like how bad those substances can be, things like lye can actually cause really deep injury in like 3 to 5 minutes of exposure. So oftentimes patients aren't even getting to the ER in that amount of time. And concentrated ammonia can actually cause a really bad damage in even less than a minute. So getting irrigation going really early is super important for these. And alkali exposures also, when I was kind of doing my research on this, it causes like an ischemia, like a vessel ischemia, and it causes the eye to kind of look very white when there's been a lot of damage. I thought about putting a picture, and I really don't like eye stuff. So I was like, you guys can Google that if you're interested in seeing what that looks like. It's pretty haunting and kind of scary, but I'm going to remember that alkali is way, way worse than, than some of the acids. So irrigating is really important. Acids more often cause like a necrosis or ulceration when there's an acid exposure to the eye. So irrigation of the eye until neutral pH is reached is really important. So pH of about 6.5 to 7.5. Alkali exposures can require irrigation for 2 to 3 hours. The way we typically irrigate is with IV tubing with a Morgan lens. Our emergency department does have Morgan lenses. I'm hoping that's kind of across the board because they are really helpful to just make sure you're really getting in behind the eyelid and getting kind of all of the chemical out. The other option that I did kind of see, though, if Morgan lens is not available, is like a nasal cannula that you just put kind of at the top of the bridge of the nose and try to let the water run through. The kind of thing about that is it may not get under the eyelid very well, so you might have to kind of help to retract back the eyelids while that's happening, which is not going to be very pleasant. And don't use a Morgan lens if globe compromise is suspected. Just using water or isotonic saline should be fine. In my research, I was seeing a couple of other chemicals that can be used like buffered eye wash solutions, but I don't think, at least the first one, the diphoterine, is FDA approved yet. So I don't think we have any kind of access to that in the States, but they are doing research in Europe, and they think this might be actually better than water or saline in certain cases. So that might be something that's kind of coming down the pike that we might get approved, and then we might start seeing it in our practice. To measure the pH, you can use pH paper, which is the easiest because it's a little bit smaller, and you can just kind of put it on the lower eyelid. Urine dipsticks work too. Just making sure that it's a brand new container of urine dipsticks, and maybe saving that for like eye exams if that's what you have to do. And they're just a little bit kind of clunkier, a little more uncomfortable for the patient to use as well. And whenever you're irrigating, proparacaine is super helpful to try to make them a little more comfortable because it's really a painful kind of thing to have those Morgan lenses and that irrigation happening without any kind of analgesia. But you can use other things too. You can just give them, pain medications as well. After you irrigate, you want to give it a little bit of time before you just check the pH, maybe about 15 to 20 minutes, because you might be checking the pH of the water if it hasn't kind of totally cleared up. So in order to really check and make sure the chemical is gone, you want to give it a little bit of time after irrigation has stopped. And if it seems like you're irrigating and irrigating and irrigating and it's just not working, the pH is just not budging, kind of look for particulate matter in the eyelids. Sometimes they can kind of capture like little particulates that you need to get out with like a Q-tip, and then that will help with the actual irrigation. And then always call ophthalmology too. So water is not ideal in a couple of different chemicals. I'm not even going to focus on these chemicals. They're here for reference. And what I was looking up in research is that the chemicals are very few and far between that you really shouldn't dump water on. And it's usually not a reason, like looking up the chemical is not a reason to delay irrigation or decontamination. You should always just start with water. And if you figure out that the chemical is something that doesn't respond well to water, then kind of shift from there. But the risk of delaying treatment is much greater than the risk of using water on anything. And in most cases, the patient will know kind of what they were exposed to. In other cases, it's, again, you're just going to have a better percentage chance of making sure they're okay by just starting to dump water. There was quite a bit of research that the irrigation starting right away actually delays their hospital stay, definitely lowers how severe the injury is going to be. So irrigation with water is most important. So the burn can actually be a lot deeper than it appears in the case of chemical injuries. It can cause some deep tissue injury that's not necessarily visible. That's why the irrigation is so important, and also frequently re-examining the patient while they're in the department. Because of the same reason we discussed at the beginning, the chemical could still be there, so it can still kind of be damaging through those tissue layers. So continuing to monitor and see if there's more redness developing or blistering, or even ischemia that's occurring, is super important, and also getting the burn team involved. Poison control was super, super helpful with the patient that I had. We worked really closely with them. I think they were just really excited to not have like another Tylenol overdose, or not, like this was just something different for them. And so, I mean, they called us back every like 20, 30 minutes. How's the patient? How's it going? What are you guys doing? Has he been decon? They were asking all of these questions and continuing to actually research the chemical as well, because it wasn't something they hear about every day. So anytime they got more information about the chemical, they would call us back and say, "Hey, did you guys know this?" I'm like, I got to get off the phone. I got to go take care of the patient. But they just kept calling back. But they were super helpful, and really interested in what was going on. One of the most important chemicals to have in mind, of things that can be really, really bad for the patient, is hydrofluoric acid. It's super corrosive. When it comes in contact with the skin, it can cause local injury, but if this becomes a systemic reaction, it can be fatal pretty quickly. So hydrofluoric acid compromises the layers just very quickly, especially at higher concentrations. When it's greater than 15% concentration, the patient will have symptoms immediately, but even lower concentrations can cause really bad injury, and the patient might not have symptoms right away. So the fluoride ions in this acid bind to calcium and magnesium in the bloodstream, and so it causes electrolyte shifts and abnormalities that can lead to death. So you can see the different grades of burn at the top of this slide. So all the way to the left is just like a whitening of the skin, and that's the grade 1 burn. Then the second one is erythema and edema and a little bit of blistering, and that's a grade 2. And then grade 3, you can actually see necrosis starting. So any of these burns, you kind of have to worry and start thinking about whether systemic exposure is a possibility. But obviously, you're going to be much more worried in the grade 3s. So the electrolyte abnormalities that happen cause cardiotoxic effects and cardiac arrhythmias because of the electrolyte shifting. The hypocalcemia stimulates the potassium to come out of the cell, and then they have hyperkalemia that causes them to have a cardiac arrest. You can see QTc prolongation on the EKG, kind of same things you would see in hyperkalemia, the peak Ts and things like that. You can start to see those changes in people with these burns. So it just has to be something that you kind of keep at the front of your mind with these types of chemicals. So this is just a really cool little chart. Dr. Sabrina Rahman, I was talking with her and telling her I was giving this presentation, and she was like, "Oh, I've done something on that before." So she sent me some images and some tidbits about including things in the slide. So shout out to her. That was super helpful. But I just loved this visual, and can be something to go back and reference. So to treat this, it's a really interesting treatment. You actually use calcium gluconate. You can use it topically, especially if it's that grade 1 type of burn. You mix it with Surgilube and put a glove over the hand of the patient, just let it sit there. And you monitor them for about 30 minutes, letting it kind of sit to see if that's taking effect and working. You can also inject calcium gluconate directly at the site. Again, that's kind of for the earlier burn, and that hasn't seemed to go too deep. And then intra-arterial injection of calcium gluconate, which was, that's kind of sounds crazy, but calcium gluconate or calcium chloride, that's especially if you're worried about the necrosis and the total systemic involvement. And then if patients get this in the eye, ingest it, inhale it, it's also really, really bad. You try to irrigate that out, and trying to call the specialist to help with those things as well. But also using the calcium is very effective. Oops. All right, so just a couple other things that we might see a little more often chemical-wise in the emergency department. Cement. This one was kind of surprising to me. It has a high pH 10 to 12, and it actually rises as it sets. So if a patient is exposed to wet cement and then they come in and it's kind of dried on their skin, they might actually have more of a chemical burn from that. Patients mostly have those complaints on their lower extremities, and symptoms can occur some hours after they were exposed. They might come in with burning, redness, vesicles. Airbags also contain chemicals. We see motor vehicle accidents all the time. And if the airbag perforated, it can actually release some of those chemicals that can kind of get into patients' eyes. It can kind of burn their skin. And it's just something to keep in mind. I think oftentimes we see like little airbag, like, people get little abrasions and things like that. And we say, oh, it's okay. But if a patient's really complaining about it, then maybe consider whether or not the airbag actually perforated and it's truly chemical that needs to be irrigated off of them. And really important in the eyes too, because these are known for that particulate matter that kind of gets stuck in their eyelids. So it's important to try to swab all of that out and really irrigate their eyes if they're complaining about that. I just put some information for poison control. We all have the phone number, but I was looking more on their website than I ever have in order to research some of this stuff. And it was pretty helpful. They have little home safe home type things and, little ways to make sure that the chemicals, the 1 and 2 year olds aren't getting into things and tidbits that would be helpful for us and for the patients. So they had a lot of information on their website. And then OSHA did as well. So they have this big chemical database, super helpful for these random chemicals that some of our patients might be exposed to that we've never heard of before. So for my patient case, he was totally stable during his whole ER stay. It's actually a pretty uneventful case overall, which is good for us and for the patient. It just brought up all of these other questions and things that we needed to think about. But he didn't have any sign of worsening, skin irritation. His pH of his eyes were normal. I did the fluorescein stain. It looked good. We did irrigate him fully, and then we did the Morgan lens for like 2 liters of saline and rechecked the pH and everything was good. We still sent him over to the burn team. They just were interested because this was a different type of chemical. They wanted to monitor him for a little bit. Ophthalmology would see him there as well. And that was just the best plan for him. But ultimately, they just discharged him later that day after watching him for a little bit. And he had a totally fine outcome, which was great. It was just really interesting, all the things that we needed to think about for him and how many people we needed to involve. And so I just thought this was an interesting thing to go over. So those are my sources. And thanks. That's it for me.
Thank you, Kathleen. That was truly a fantastic presentation. I learned a lot myself, and I hope everybody on the call did as well. If anyone has any questions for Kathleen, we will, obviously she's going to stay on the call with us here until the end, but please drop them in the chat. I think we should have a little bit of time at the end to go over any questions, so please don't hesitate to drop those in the chat, and we will address all of those at the end. But again, Kathleen, thank you so much. It was truly a fantastic presentation. Thanks. All right, so we're shifting gears here to my portion, and so I'm going to be talking about high pressure injection injuries. So just a little background on where my idea came from for this case. I had a high pressure injection injury case at Franklin Square, and I did not know a lot about the pathology or what it could do to the skin or the body or what to do with it. So I also, just like Kathleen did with her case, I did a lot of research and learned a lot about it. So I figured it would be a great opportunity to spread that knowledge to all of you, since this is not something that we'll see regularly. So let's start with talking about what a high pressure injection injury is. So it's a rare injury that you'll typically see happen with pressure washers, people who are operating industrial equipment. And what happens is they somehow come into contact with the stream of pressured fluid. So whether their hand slips or somehow their grip is wrong and their hand swipes in front of it, it can also happen on the lower extremities as well. But essentially what happens is there's so much pressure behind those machines that it is enough to break the skin and sometimes penetrate that substance deep into the layers underneath the skin. So again, the most common sites of injury are going to be your hands, and incidentally, it is the non-dominant index finger, and that is because you're going to likely be holding the object with your dominant hand. So the hand that's injured is likely your non-dominant hand. But again, it can happen anywhere on the hand. We do also see these on the upper and lower extremities if people just lose control of the equipment. So why are these injuries important? The big picture here with high pressure injection injuries, and similar to chemical burns, is that Although the skin itself may look like a very benign abrasion, even a puncture wound, what can happen underneath the skin can be catastrophic. So although the wound may appear very superficial in nature, that injected substance can cause tissue damage that is very extensive under the skin and can also track proximally to the mediastinal area in some cases if it does involve the hand. So although it may look isolated and very tiny at the time of appearance, what can be happening underneath the skin that's not seen to us can be catastrophic. So what type of material is injected? So we talked about this a little bit, but any type of high pressure substance. This can include paint, air, water, solvents, gasoline, oil, grease. The list goes on and on. And just a little tidbit here is that industrial fluid injection via high pressure apparatus often does have limb-threatening consequences for workers. So just bear in mind when you are, seeing patients with these injuries that they can have a lot of bad outcomes. So just to give you an idea of how much pressure is injected, so it's 10,000 pounds, can be up to 10,000 pounds per square inch with velocities up to 400 miles per hour upon injection. And so I found this really, quote that was from one of the research articles that I saw that really put that in perspective. So the magnitude of force is equivalent to 1,000 kilograms falling 25 centimeters into the affected digit. So that is a lot of pressure that can be injected. So again, although the entry site may look very benign, what can be happening as a result of all of that pressure can be very bad. So what happens after injection under the skin? So this process will take place in 3 phases typically. So your phase 1 is going to be a result of the direct impaction of that pressure injury. So what you can have is neurovascular compromise from the pressure underneath the skin. You can obviously have swelling like we can with any injury under the skin. The bigger concern here is the possibility of compartment syndrome. So you're having thousands of pounds of pressure that's injected into potentially a small area that can lead to a huge inflammatory response. You can also have tendon and ligamentous injuries. The pressure can itself lacerate those tendons and ligaments. It can also involve the neurovascular structures, lacerate nerves, and sometimes have arterial and venous abnormalities as well. And rarely it can even fracture bones. So keep that in mind as we get into our workup on this, but just keep in mind as well that the injected material will not stay isolated to that one area. What it typically does, it'll flow along the path of least resistance and can travel approximately, and again, can go all the way up to the mediastinum in some cases. And another note about that is that the path of least resistance is often where our neurovascular bundles live. So just keep in mind that although we can't see it, there can be bad things happening to those structures as well underneath the skin. Moving on to phase 2, this is where you have that inflammatory response as a result of the injected material. So once that material is injected, then you will have an inflammatory response. Your body will see it as a foreign body. So any type of foreign body that your body has that is not supposed to be there, it'll strike an inflammatory response against it to try to get it out. And so that inflammatory response, unfortunately, can again be catastrophic. If there are certain types of materials that are injected under the skin that are cytotoxic, they can be deadly to the cells, then that can cause a significant inflammatory response and necrosis to the surrounding tissues. Just a note about this, air and water injections typically have a less inflammatory response, and so your body can typically handle those a little bit better than some of the other substances. And last but not least is phase 3. So this is a more rare phase, so not all of the cases get to this phase. But this is a very bad phase, and this is where you can get a secondary microbial infection from direct bacterial inoculation. So if we think about any type of break in the skin, we all know that one of the biggest risk factors for infection is if we have a break in the skin, and our normal skin flora, so mainly our staph and strep, can enter our skin through the broken wound. Now think about your high pressure injection injury. You have over 1,000 kilograms being injected into your skin under high force. So all of that skin flora that lives there normally suddenly gets pushed deep into the structures underneath the skin. So that's where this phase takes place. Beyond that direct inoculation from the pressure injury itself is you can also just develop a bacterial infection from all that inflammation and necrosis that's occurring because of phases 1 to 2. So all of that coupled together creates a very bad breeding ground for bacteria. So infection is a huge concern in these cases. And I did just put down here at the bottom of the slide, just a reminder to sum all of that up, that your biggest risks for these injuries and why they are so important is that you can develop compartment syndrome, bacterial infections, tendinosynovitis if that infection starts to involve one of your tendons in the hand, septic joints, necrosis of the tissue, and ultimately can lead to systemic infection, loss of limb, and fatality if these get bad enough. So what your typical patient presentation is going to look like. So you will typically have a patient that's coming in from work, often an industrial fluid washer or some kind of pressure washing company, and they're going to present with an injection injury. The patient will often say they lost control of the washer device and it either swiped or directly impacted their hand or other part of their body. Now, this is where your history comes into play. And, we all say that the history is one of the most important, if not the most important part of your workup on any patient. So we need to figure out what type of fluid was injected. And again, we know that if it's air or water, we don't have to worry quite as much. But if it's something like gasoline, oil, paint, then we want to worry quite a bit more. The next big question is going to be, was the patient wearing protective gloves? Now, I will say from experience with a case like this and also from my research, most of these people, if not all, should be required to wear protective gloves if they are pressure washers. But whether or not they do, it may be more difficult to operate the machinery with a big glove on. So getting that history from them is going to be important because those protective gloves can lessen the risk of these bad outcomes. Up next is going to be your basic questions. Anytime somebody comes in with an injury, do they have paresthesias or weakness? Are they noticing anything different in the sensation or the motor function of their hands? Has there been any rapid swelling? We want to figure out if they're going to be higher at risk of developing a compartment syndrome. And a big one's going to be the time from the initial injury to the ED. So there is some research, and we'll get into this on the next few slides, but time of injury is super important. So time of injury to the OR is very important for people who have things like paint and gasoline and things like that injected under their skin. So at the 6-hour mark from the time of injury to the OR, we start to see a worsening outcome in these cases. And last but not least is your tetanus status. So up next is your physical exam. I did put a diagram over here just to remind us of how we quickly can check the motor and sensory function of the hand. There's a few different ways that we can do this. One of the things I do for all of my hand cases is just basically say, patient can make a thumbs up sign, that checks off my radial nerve. Patient can make a fist, they're flexing their digits, that checks your median nerve. They can do the peace sign, even the scissors, open and close, that'll check their ulnar nerve. And the AOK sign will check that anterior interosseous branch of the median nerve. So that's a quick thumbs up, make a fist, peace out, and AOK. I write that on almost every hand case that I see just to show that my nerve motor is intact. During my research, I found actually another quick way to do this, which I thought was kind of cool. It's the rock, paper, scissor way of doing it. So again, your rock will check your median nerve, and that innervates the flexors of the hands. Your paper is your radial, so you can also check your radial by doing a paper sign. So having the patient basically extend their wrist and their fingers to the paper sign, that'll check your radial as well. And then again, your scissors for your piece or your piece out will check your ulnar. So rock, paper, scissors is another way to check it. And then don't forget your AOK at the end there. And then again, into your sensory portion of your hand, you can take a look at this diagram. We all know where the nerves innervate for sensation, but a quick way to check these nerves is to check the first dorsal web space for your radial nerve. And then for your median nerve to check the medial tip of the index finger. And then for your ulnar to check the lateral tip of the pinky finger. So if you want to quickly document a neurovascular, or excuse me, a neuro exam for your hand, then you can quickly document those things that you've checked all of those. And it takes under 9 seconds to do all of those things. Again, don't forget about your vascular exam as well, right? So you want to check your radial pulse, your ulnar if you can as well, and then your cap refill at the digits. If you are having any concern at all that there's any sort of vascular abnormality with the hand, you think maybe one of the digits is not as well perfused on your cap refill testing, you can actually test the peripheral pulse of each digit with Doppler. So just pop a Doppler on there and you should be able to hear your pulse there at the end of each digit. So that kind of covers your neurovascular exam for the hand and what you should do for these injuries if they are involving the hand. Of course, if they're involving other parts of the body, you want to check the neurovascular status of those areas as well. But again, your hand is going to be your most likely area of injuries for these. Beyond all of that, I think an important thing to do would be to capture a cerner photo of the injury so that whoever you're consulting, or if you discharge the patient and you want them to come back for follow-up, they can take a look at what the injury looked like when you first were seen, or excuse me, when you first saw the injury and the patient was first seen, versus what it looks like when they recur for a follow-up visit. Up next, again, you want to document perfusion of all your digits, your motor and sensory function. And a big thing here to not forget is to make sure the pain's not radiating up. And if you ask the patient, is the pain staying right where it is, or is it radiating upward? Then you want to make sure you begin to assess things structured beyond that site, because that would be greater concern that the process itself is radiating upward or the fluid itself is radiating upward. So if it's involving the hand and they're having pain upward, go ahead and check out that forearm, check out the wrist, check out the elbow, the shoulder, all the way up into the chest and the axillary area, because don't forget that you can have involvement up to the mediastinum if these injuries are significant enough. And again, the bigger thing here, compartment syndrome, do not forget it. That's your highest risk for these cases. So serial exams, if they're in your ED for 2 hours, make sure you're reassessing them and documenting as such. So what do we do next? So we have a detailed history, we have a detailed physical exam. Our next step is going to be obtain an x-ray. So I have an x-ray over here on the right-hand side, and you can see in the circled area, that is some substance injected under the skin. That's actually paint under the skin. So it looks as a tiny minor puncture wound can have all of this foreign body underneath the skin. Okay, so you not only want to check for that injected substance, but you also want to check, it doesn't show on this x-ray, but we will have another one coming up, subcutaneous emphysema showing that inflammatory response tracking upward. And also you want to check for obviously any fractures, because again, if it's significant enough, we can unfortunately have breaks in the bones from these injuries. After you have all of this, your sonar capture pictures, your detailed history physical exam, you have your x-ray, then your next step is going to be the consult the hand specialist. If you're in the Baltimore region, Union Memorial hand specialists are happy to hear about this case. If you're in the DC region, then consult whoever is local to you for your hand services. I actually was able to discuss these injuries with Dr. Meems, who is one of our head hand guys over at Union. And I said to him, I was like, if I have a low risk case, I think it's, the x-ray is negative, there's no signs of anything under the skin, neurovascular, the patient looks good, would you still like a call? Is this something we should still consult on? And his brief answer was, we are always happy to take calls. Sometimes these cases will not have to be transferred, but it's never going to hurt to consult the specialist. And I would say that in cases like this, where the outcomes can be terrible if it's a bad enough incident, then I would say just give them a quick call, run the case by them, and make sure that they're guiding you on the best way to handle these patients. Sometimes they can say discharge them, we'll see them in the clinic tomorrow morning, give them, compartment syndrome return precautions, but making that call is only going to better the care for your patient. And again, in the consult, you want to have everything lined up and ready to go. You want to know what your x-ray looks like. You want to have your hand exam down to a T, and you want to have that great history on what was injected, what time it was injected, any symptoms the patient is having. While you're making these consults, some medications to consider, of course, your tetanus prophylaxis. If the patient is having pain, which I will say they typically do not have a ton of pain. They may have some burning or irritation at the site of injection, but most of the time the pain is going to be mild. But if they do have pain, definitely give them pain control. And then if you have an injury that you think is going to be catastrophic, meaning you can see a visible foreign body injected underneath the skin, you can see some subcutaneous emphysema, or you have a significant concern for the patient's symptoms, then I would consider prophylactic antibiotics to cover that third phase of the injury. If they have that injected material under the skin, then we want to cover for potential inoculation with prophylactic antibiotics and also inflammatory response that can lead to infection. So typically what you'll do is a third generation cephalosporin to cover for your gram-positive and negatives. So what happens if transfer is indicated? So for low risk injuries, patient may just be observed overnight for signs of developing compartment syndrome. So you make that call to Union, you say, I see some subcutaneous emphysema underneath the skin, but I don't see an actual foreign substance. It sounds like it was water that was injected. How do we proceed? Most of the time, these will just be an overnight observation for signs of compartment syndrome. Your body can handle injections of air and water much better than it can develop injections of actual substances that are concerned, like the paint, the gasoline, the oil, things like that. For your higher risk injuries, we want to get these patients to the OR right away. So we have an injection injury like on the previous slide. We see some paint underneath the skin. These patients need to not be delayed for OR exploration of the injection site and surrounding structures. Keep in mind, these substances can quickly travel. So what will ultimately happen is these sites will be completely opened up and exposed until they see areas of clean tissue that does not look inflamed, that does not look necrotic, and does not have any foreign substance. The goal of the surgery is going to be, again, to remove as much foreign substance as we possibly can and to debride any dead or devitalized tissue. And of course, unfortunately, if there is no improvement after all these measures are taken, sometimes these can lead to amputation if the injury is significant enough. So what affects our prognosis? We talked a little bit about this, but I just want to reiterate the time of presentation from the initial injury is going to be the most important piece of your history, in addition to the force of injection and the volume injected. Those pieces of history are so important. So we need to make sure that we get these patients seen and consulted on very, very rapidly as soon as we can from the initial time of injury. We want to know how much force was used. So if, again, the greater the force, the greater the risk of direct inoculation of bacteria, the greater the risks of injuries to the structures underneath the skin, and likely the greater the inflammatory response the body will pose against it. And again, in terms of what is injected, we need to make sure that we're looking for those cytotoxic substances versus things like air and water. So composition of the material injected, again, you want to look for those scary high risk injected materials, and there is up to a 50% risk of amputation rate for organic solvents. Okay. And delays to the operating room, like we said, that 6-hour mark, we want to get those patients who need to go to the OR there as quickly as we possibly can. So this next slide is just a great way to show you how catastrophic these injuries can be, even though they look benign. So in your picture A up on the left-hand side, we see a very tiny puncture wound to the second digit on the right hand. Tiny, right? Looks completely benign. But that X-ray right next to it shows that you have a significant amount of radiodense fluid, and then you can see the air tracking upwards, that subcutaneous emphysema tracking all the way up to the thenar eminence region of the hand. So that just shows this tiny, tiny puncture wound can have catastrophic incidences happening underneath the skin that we cannot see. Okay, going down to the next picture, that shows what the digit looks like once it's opened up. So the injury in the area of inflammation goes all the way up to the wrist area. And then, unfortunately, the next picture shows areas of necrosis that happened 12 hours after the injury. So that's why that 6-hour mark is so important in getting these patients managed. And so again, the takeaway here is that essentially benign appearance of a puncture wound or an abrasion can have catastrophic upstream consequences. So our takeaways from these types of injuries: any wound in the ED, take your thorough history. The patient may come in and not know exactly what happened to them. They just have some type of laceration or some type of puncture wound. So making sure we understand the mechanism of how they got that injury is going to be super important. Your HPI, or excuse me, your high pressure injection wounds, they may appear very, very mild, even a tiny puncture wound, but they can have significant injury that's not visible to you happening underneath the skin. Another takeaway would be to have a very low threshold to consult your specialist with the hand centers to review the case. If you're concerned at all about the patient, advocate for them. Request transfer. Our hand specialists are extremely, extremely helpful and reasonable, and they would likely not decline an observation overnight if you have concerns about these types of cases, considering how bad the outcomes can be. Document your clear neurovascular exam on these patients and include your tendon function on these, because again, these can lacerate your tendons. And do not skip the X-ray. This is one of those cases where we want to make sure that we utilize our X-ray imaging to look for injection underneath the skin of material and tracking subcutaneous emphysema. And last but not least, do not forget your Tdap, and consider your prophylactic antibiotics if we're concerned these are going to make their way to phase 3, where we're having either inflammatory response causing a high risk for bacterial infection and or so much pressure that we've had direct inoculation of bacteria under the skin. And these are my references. That's all I have for you all today. If anybody has any questions, we can go ahead and take those now. And if not, again, thank you so much for joining us for our first MEP APP quick review. We look really forward to learning with you again soon. A huge thank you to Kathleen for collaborating with me on this first quick review. It's been fantastic working with you, and you did a truly fantastic job. Just a background on how we decide these cases is we just basically take a look at any cases or pathologies that we rarely see, but something strikes our interest and we think it would be important for us to hear about. So if any of you ever have any ideas about cases or pathologies that you would like to have us present on, just go ahead and send them our way, and I'll drop my email over here in the chat as well. It looks like we have a question from Gerald.
Yeah, Brooke, I just wanted to say, from an urgent care standpoint, we should still try to make the same consults during the week. It can be a little harder because we don't have on-call people per se, but Washington Hospital Center, if you call their main operator, they can usually get you in touch with a fellow or a resident or someone. And if you can't, then at a minimum, you should do a MAC3 consult on these patients to determine if they need the ER. So I just want to throw that in from the urgent care standpoint.
Absolutely. Thank you, Gerald. That's really helpful to know that you all potentially have the capacity to make those consults. But again, rest assured that if not, we are happy to take these cases in the EDs. And again, through MAC3, that's a great idea. Thanks, Gerald. Chris Boldy.
Hey guys, that was awesome. Great. Hey, I know you touched really great on the hand for these high injection, and every year, don't be really careful on these non-chemical injection. Every year we get someone out back in flip-flops washing their deck with a pressure washer, and they hit their foot, and they usually present to the ER like 12 hours later. And it's a very low acuity from the triage point of view because they don't think much of it. But I would really urge everyone to keep that high on your, it's usually pretty urgent because the compartment work is kind of set in. So when you see these pressure injuries, even though there's no chemical involved, but if it's gone a period of time and they present to your ER, just have a real high level of suspicion to see them sooner. But yeah, otherwise, great job.
Absolutely. Thank you, Chris. I completely agree. Thank you so much. Any other questions before we wrap things up here? Give you back a little bit of your time. All right. Well, thank you so much for joining. We really, really appreciate your participation. And we hope to see you all at our next quick review. Have a great day.
Thanks, Brooke.
Thanks, Kathleen.
Thank you.